I'm Sam Chidwick, and this is Emma Price.
Hi everyone.
We're both podiatrists from Superfoot, Cheltenham, and we are the owners of Pedia, which is a directory of UK podiatrists and an information resource for patients all about foot and ankle pathology and podiatry. So if you head over to podipedia.co.uk at any time, you can get loads of information on there. So we have a patient with us today, Merrick.
Hi.
Thank you for joining us. Merrick has booked into our clinic because he's developed pain in his right heel. How long have you had this pain for, Merrick?
About 3 weeks or so, just on a walk, new pair of walking boots, walking the dogs, just felt a bit of a discomfort, sort of sharp pain in the heel.
Okay.
Carried on walking just because, I was halfway around, so I needed to get back. It kind of eased up a little bit, pushed through it. Mm-hmm. Then if I've sat down for any length of time, like 20 minutes, half an hour, etc., and then get up, then I get a sharp pain again. And then again, after sort of 15 minutes or so, it kind of eases.
Okay.
And then if I do the same again, rinse, repeat, it's sharp again.
Perfect. You put on your forms that it was a new pair of walking boots, sorry, wasn't it? That you bought
that's right. Yeah, new pair of boots.
Yeah, okay. And at the time, did you feel a specific injury? So like a rip or a tear? Do you remember twisting your ankle, going over a tree root or anything in particular?
Not really, no. Just generally walking. I mean, I don't think so.
Okay.
That's about it, really.
Perfect. And have you had any other problems in the past with your feet? Sorry, I know you've put in your forms about an Achilles problem previously on this side and a knee problem on the right side as well.
Yeah, so I got a stretched PCL I did 25 years ago or more, probably.
Okay.
For those watching, a PCL is a posterior cruciate ligament, which is a knee ligament.
Mm-hmm. So that has a bit of instability, and I generally have more problems with the right leg, I suppose, and an Achilles tendinopathy several years ago, which has never come back, thankfully. But
okay, brilliant.
The right side gets a bit of beating.
Right, no problem at all. So we do find that's not uncommon, that you might have heel pain on one side or on both sides. And also sometimes a lot of patients say, oh, it's always my left side, or it's always my right side. It's my right shoulder, my right knee, my right hip, my right foot. That is not an uncommon thing at all. So in this case, we're just going to start with some palpation around here. So the most common site for anyone suffering with heel pain, if it is plantar fasciitis, the most common area is underneath the heel, in this area. So not at the back of the heel, which is more of the Achilles tendon. So it's pain underneath the heel. It can be central, but we often find it's slightly to the inside. So we call this the medial side, inside of the body, and slightly into this area. There's a little area underneath here of the calcaneus, of the heel bone, called the medial calcaneal tubercle. And where the plantar fascia attaches, normally if you press into this sort of area, you can elicit a little bit of discomfort. So is that, he's nodding at me, which you can't see, but I think that's the area.
It's a little tender.
So some people feel it a little more centrally. Some people can feel it more on the outside. We call this the lateral side as well. So the plantar fascia is comprised really of different segments. So we have a central band, a medial band, and a lateral band that all run from the heel and run underneath to the forefoot. The lateral band comes down here, medial band, and it generally has a slightly central to medial bias of where people feel that pain. In Eric's case, I don't think this heel pain is necessarily, it may be associated, but it's not necessarily associated with tightness in that ankle joint. Now, moving down, if you just relax your foot a little bit for me, if that's okay. That's lovely, perfect. His pain is here. Do you get any pain into the arch as well? Or is it mostly localized in the heel?
Mainly localized in the heel, yeah.
And you said it's worse when you sort of stand up first thing in the morning or after you've been resting.
Yeah, anything over sort of 15, 20 minutes sat down.
Yeah.
And especially overnight. When you've been off it for 6, 7, 8 hours or so.
So we often find the reason for that is that when you're sleeping or resting, your foot is relaxed and adopts to this position. So the plantar fascia here almost shortens. The calf muscles do shorten as well when you're sleeping. And then when you stand up in the morning or you go to the toilet in the night, boom, it suddenly has to, it's under tension, it's under load, and that puts a lot more tension and stress through the heel area. So that's why people tend to get what we call that sit to stand pain, or that pain first thing in the morning. And often people will limp a few steps. So I find a common one is they sort of stand up and then it's a bit of a limp like this, but then the more you walk, it sort of loosens off and you can get going again. And that's not uncommon at all with plantar fasciitis, with heel pain. In terms of our assessment, moving further forwards, Merrick ranges of motion generally in his feet are normal. Now, for you sort of looking at this at home, we don't expect you to necessarily know what normal is, but big toe is one that you can test yourself as well. Now, the plantar fascia, particularly this medial aspect, right, inserts into the base of the big toe. Your normal range of motion for your big toe, I often put my finger out there as a guide, so that's creating about a 90-degree angle. How much can you then bend that big toe up? Now we can see a little bit of enlargement around his big toe joint here, and there is a little bit of bony restriction of this joint moving upwards. Have you injured this before? Had any problems with this before?
I don't know if I've injured it ever, but I definitely get, I know it's restricted because I get sharp pain if I'm in a press-up position.
Yeah, okay.
I can't put full weight through it.
Yeah.
And if I'm sprinting at full tilt,
yeah,
then that gives it a bit of discomfort.
Yeah, of course. And because you mentioned as well, before in your forms you play tennis, you go to the gym quite a lot, so you notice that when you're doing different exercises. Then can you just bring your left foot up for the camera as well? Because I noticed before, if you look at the 2 feet together, you may see a different color in Merrick's feet now, but that's nothing to be alarmed by. It's just where that leg's been hanging down. The big toe on the left foot is relatively straight. In the right, it goes into a slight valgus angle, or some people may call that a bunion. And if you look, the gap between the first and second toe is reduced on this side. So it's in a slight valgus angle, as well as having slightly reduced range of motion. So we'll see if that impacts our testing later on as well. When we bring the big toe up, this is something called the windlass mechanism. It pulls on the soft tissues of the arch, including the plantar fascia, and actually puts them under tension. So when you're walking, your fascia is actually being worked when the big toe is able to bend. If you have a bunion, a hallux valgus, or what we call structural hallux limitus, you can read more about these on Pedia website as well. There's more information about these specific conditions. If there's reduced range of motion, there is not as much work or going through the fascia and the soft tissues, so they're not being loaded by your natural movement every day, which can over time lead to a sort of degeneration or almost a weakening of the fascia because it's not being loaded properly in day-to-day activities. So that could be biomechanical cause of this pain. Now, you've only had this for 3 weeks. We're not going to worry too much about that, but if it's something that persists, this might be something that we want to talk about in the future. That isn't an essential thing by any means for assessing plantar fasciitis, particularly not if someone's only had it a few weeks and there's no mechanism of injury or a rip or a tear. So don't expect your podiatrist to have to do this. It may just be a useful thing, and it's useful from an anatomy perspective to be able to look at the fascia in a little bit more detail here and compare it to the unaffected side on the other foot. Now, ultrasound just uses sound waves, Merrick, so it's completely safe. There's no exposure to radiation or anything like with an X-ray.
Good to know.
Right around on the screen. How is that showing up for you? I can increase the gain a little bit on here, which might make it a bit more visible. Perfect. So we're just having a little look in what we call the longitudinal axis at the plantar fascia. Now the image is upside down. This is a fat pad underneath your heel. This is actually your heel bone here, and the plantar fascia that we're interested in is this band running through the foot here. So I can just move the probe around. If I just heel toe the probe like that, it makes the fascia, this area, stand out a little bit from the fat pad above. And if I bend the big toe, we should be able to see a little bit of tensioning in that tissue, which we just about can. And this is this pretty much over the area that's uncomfortable?
Yeah, that's a good spot.
But there was a little bit possibly of thickening in that area there. I've got the gain up because the room's not very dark. It might be a little bit harder. That way? So in that area, it's a little bit subjective measurements always, but it's coming in at around 3.9 mil. It's a little bit harder to visualize the fascia around this area, which could be indicative of a little bit of inflammation or pathology in that area. The normal thickness would be between about 2 and 4 mil. So if I'm being generous there, 5.5 mil, possibly a little bit thickened there, which could be a visible sort of appearance of what you've presented with. If we have a look at your left foot in comparison now. But yeah, I mean, we've got much clearer deep section and superficial section of the fascia in that area now on this side. Just eyeballing that, I can assume it's going to be about 4 mil, yeah, 4.1, 4.2 into that area. So we know that the right is about 1 millimeter thicker. Now, what does that tell us? It's useful information. I would normally, just as a caveat, I would normally scan that in more detail, look at it in different axes, but just for the purposes of this, that gives us a little bit more information. Making a noise. Perfect. So that tells us, or gives us a little bit of information about possible thickening of this right plantar fascia, which is in keeping with your symptoms. Now, the longer you've had something like plantar fasciitis, the thicker this tissue will become over time, and it almost becomes what we call plantar fasciosis. You want that window? I think you can leave that one, Emma. Yeah, I think we're all right. We're bright enough again. So over time, it can become more thickened, which becomes plantar fasciosis, where the tissue is maybe not quite as healthy anymore. But Merrick's looks hopefully nice and healthy. It's quite an early acute problem with just a little bit of thickening in that area. Now, that could be related to 3 weeks ago. It could be related to this big toe and years of walking with some reduced range of motion in there. Effectively, though, based on all of our sort of tests and observations, our diagnosis at the moment is a 3-week history of plantar fasciitis or plantar fascia pathology into this central medial band into here. So what we need to do, Merrick, is work out how we're going to help you and how you're going to get better.
Excellent.
Which is why you're here.